many, led by our cardiology fellows. And thanks, Inga and Tom, for taking the time today. First off, a quick announcement. I've been lucky to have Oyeri Onuma as my co-chair over the past 2 years, and as many of you know, she has taken on an important role in global cardiovascular health at MGH, where she's gone back to. And with Eric's permission, I'm pleased to announce that Catherine Clark has joined the co-chair of the Grand Rounds Committee and will be taking on for next week. Thanks, Catherine, for joining us, and looking forward to a great Grand Rounds year and the years ahead. So today we have a special session that focuses specifically on the scientific sessions that happened a few weeks ago. I know we had a break for Thanksgiving, so many of you may have seen these studies presented at different locations. But the idea was we used to do this with faculty predominantly leading the discussion. But we wanted this to be an opportunity to expand for fellows to find the studies they like the most. This is not going to be a comprehensive overview of AHA, but studies that were fellow favorites, so to say. So Tom and Inga picked out studies that they like. They tried to be as diverse in the selection of subject matter, but I'm certain there'll be notable exclusions. But thanks for doing it and educating us about this. So first off is Tom Breen, who he went to Albany Medical College for medical school, was at Mayo Clinic for residency, and has been a cardiology fellow here for 2 years and plans to do interventional cardiology. So Tom's gonna flag us off today. Thanks.
All right, thank you, Rohan, for the introduction. So like he said, we're going to be presenting the 2022 AHA scientific sessions, some of the updates and a few trials that we found to be particularly interesting. I'm going to be starting the first half, and then Dr. Inga Melvin's daughter is going to be taking over the second half. A couple disclaimers here. Sorry, Dr. Velasquez, but we're not going to be presenting your trial, Transform Heart Failure. We didn't think we were going to be able to do it justice. We want to give you an opportunity to potentially present this in the future. Otherwise, we have no disclaimers between the two of us. The studies that we picked to go over, I'm going to be starting with the first three. So I'm going to go over Strong HF, Best CLI, and then the Ischemia Extend update. And then Inga is going to take over, and she's going to present EMPA-KIDNEY, DCP, and the first in vivo editing of the TTR gene. So to start off, I'm going to be presenting the Strong HF trial. This was just published in Lancet earlier this month and presented as a late breaker in the AHA scientific sessions. A little bit of background about this trial. We know that patients are at higher risk of morbidity and mortality in the first few months after admission for decompensated heart failure. This is known as the vulnerable period. And there's been many studies that have shown that patients are not on adequate doses of guideline-directed medical therapy and have pretty poor follow-up during these first few months. There's been some concern about rapidly optimizing oral heart failure therapies due to concerns for hypotension, hyperkalemia, and renal failure. And so a lot of times physicians will, instead of rapidly introducing them all at once, will delay it over the course of months or years to get patients on optimal doses of medical therapy. So the goal of this study was to assess the safety and efficacy of uptitration of guideline recommended heart failure medical therapy, including beta blockers, ACE, ARBs, or ARNIs, and mineralocorticoid receptor antagonists on morbidity and mortality when initiated and uptitrated early after hospitalization for acute heart failure. This was a multinational, multi-center, open label, randomized parallel group study. They recruited from 87 different hospitals in 14 different countries. The notable inclusion criteria included that patients had to be admitted for acute heart failure within the past 72 hours. They had to have an NT-proBNP of at least 2,500 at screening and at least 1,500 at the time of randomization. They had to have a systolic blood pressure of at least 100 millimeters of mercury and a heart rate of at least 60 with a serum potassium of less than or equal to 5. And that was to ensure that they could be rapidly uptitrated on the GDMT. And then importantly, the regimen that they had to have at the time of randomization, they either had to be on no beta blocker, less than or equal to half the optimal dose of an ACE, ARB, or ARNI, and less than or equal to half the optimal dose of a mineralocorticoid receptor antagonist, or they had to be on no ACE, ARB, or ARNI, less than or equal to half the optimal dose of a beta blocker and less than or equal to half the optimal dose of an MRA. The primary endpoint here was the occurrence of all-cause mortality or heart failure readmission through 180 days post-randomization. This is what the authors considered to be an optimal dose. So aldactone was 50 milligrams daily, bisoprolol was 10 milligrams daily, Coreg was 50 twice daily, succinate was 200 milligrams daily, lisinopril was 35 milligrams daily, losartan was 150 milligrams daily, and Entresto was 97/103 milligrams twice daily. So patients were screened and then they were randomized in a 1-to-1 ratio to either a high intensity arm or a usual care arm. So patients in the usual care arm would be treated according to their local cardiologist. So they would not be seen by the study practice. They would be discharged, seen by their local cardiologist. They would manage their medications. And then they would be seen again by the study group at 90 days after discharge, and then at 180 days as well. The other half of the patients that were randomized to the high intensity care group would be rapidly put on half of the optimal GDMT doses prior to discharge. And then they would have 4 visits in person, 1 week, 2 weeks, 3 weeks, and 6 weeks after randomization. And the purpose of these were safety checks. And also at week 2, 3, and 6, they would try to up titrate to a full dose of GDMT if able. So this was basically an algorithm that the providers would use to up titrate the medications. And so the only reasons why they would not be up titrated according to this high intensity care arm, for the ACE, ARBs, or ARNIs, or MRAs, they would not be up titrated if the systolic blood pressure was less than 95, the serum potassium is greater than 5, or the GFR was less than 30. And the beta blockers would not be up titrated if the systolic blood pressure was less than 95 or the heart rate was less than 55. So other than that, they would be up titrated to the optimal dose. So overall, 1,641 patients were screened, 542 were randomized to the high intensity group, and 536 were randomized to usual care. I want to point out that there was pretty good follow-up at both 90 and 180 days. 506 patients from the high intensity arm and 502 from the usual care arm were able to be included in the 180-day primary efficacy analysis. I'm not going to spend a lot of time going over the baseline demographics. I just wanted to point out that these were mostly white males and the comorbidities were well balanced with no significant differences between groups. They did have a mix of ischemic and non-ischemic cardiomyopathy, about half and half, and they also included patients with preserved ejection fractions. This was not only patients with reduced EF. The other point I wanted to point out was that if you look at the medications they were on before randomization, really the predominant was a mineralocorticoid receptor antagonist. About 95% of the population was on an MRA prior to randomization, whereas only 36% were on a beta blocker and 64% were on an ACE, ARB, or ARNI, which is a little bit different than most heart failure studies as well as our population here. So looking at the results, this figure shows the how many patients were able to be up titrated to a full optimal dose at day 90 and day 180 in the high intensity arm versus the usual care arm. So before randomization, if you look all the way to the left, this is the ACE, ARBs, and ARNIs. Really less than 2% of patients were on a full dose of an ACE, ARB, or ARNI prior to randomization. At day 90, 55% in the high intensity group were on a full dose versus only 2% of those in the usual care arm. For beta blockers, it was very similar. Less than 2% were on a full dose at randomization. And then at day 90, 49% were on a full dose in the high intensity arm, which is only 4% in the usual care arm. And kind of similar for the MRAs, at day 90, 84% were on a full dose versus only 46% in the usual care arm. So there's quite a bit of a difference in how aggressive the high intensity care group was managing patients versus the usual care group. Looking at the vital sign results, patients in the high intensity care group had a lower blood pressure, lower heart rate, lower respiratory rate, and a lower body weight despite having the same dose of diuretics. And this is after 90 days. They also had less clinical signs of congestion with less peripheral edema, a lower JVP, less rails, and a lower NYHA class. There was really no major difference in labs aside from a higher serum potassium in the high intensity group, but no difference in renal function. So now looking at the primary endpoint, which is 180-day heart failure readmission or death, you can see on the curve on the left that this is a survival curve, those in the high intensity group did much better than those in the usual care group. And you can start to see those curves separating after only 30 days. So you really start to see a benefit very quickly within a month. On the right, you see the all-cause mortality curves. These did not reach statistical significance, but again, you can start to see those curves separate around 60 days. And in the short-term follow-up of 180 days, it was not significant, but you can imagine that would be significant if this were to be continued for a little bit longer. So again, looking at that primary endpoint, the number of patients in the usual care group who either died or readmitted for heart failure within 180 days was 23.3% versus only 15.2% in the high intensity group. And that was mostly driven by heart failure readmission. There was no statistical significance for death, as I mentioned. The other thing to point out is that they also had a much improved quality of life according to the survey that they filled out. And that was despite being on higher doses of medications and more medications. Looking at safety events, there was a higher risk of any adverse event in the high intensity group versus the usual care group. It was 41.1% versus only 29.5%. That was mostly driven by a slightly higher risk of hypotension, hyperkalemia, and renal impairment. And this may be in part due to having more visits in the high intensity group with more lab draws, thus more opportunities to discover adverse events. When you look at serious adverse events, those were pretty similar, 16% in the high intensity group versus 17% in the usual care group. So overall, while there were some higher risks of adverse events, there was no higher risk of serious adverse events. This study ended up being terminated early by the Data Safety Monitoring Board because there was a larger than expected difference in the risk of the primary endpoint. And that was based on an analysis of when 1,069 patients had been randomly assigned. So 10% of patients were not included in the final analysis because it was ended early. So some key points about this study. This shows that most patients admitted for acute heart failure really can be rapidly and safely up-titrated to the recommended doses of guideline-directed medical therapy within just a few weeks after discharge. It's important to have early visits with clinical and lab assessments to check for safety. And really, you see that if you rapidly up-titrate these medications, there's a benefit quickly within 30 to 60 days. You start to see a reduced risk of heart failure readmissions. That small increase in adverse events did not correlate to the increase in cardiovascular or serious adverse events. This does appear to be a safe method as well. Some limitations, they started enrolling patients before SGLT2 inhibitors were a standard of care. And so they really don't have any data on SGLT2 inhibitor use until the last year of study, which may raise some complexities in introducing all these medications quickly. As I mentioned, their use of MRAs was quite higher than our population and quite higher than what's shown in previous heart failure studies. Because that trial was stopped early, this does limit the power to detect some of the differences in the secondary and exploratory endpoints. And then finally, this was an unblinded study, which raises its own potential biases. So now I'm going to transition into the BEST CLI trial, which is looking at surgery or endovascular therapy for chronic limb-threatening ischemia. This was published in the New England Journal of Medicine earlier this month. Background of this study, we know that chronic limb-threatening ischemia affects up to 11% of patients with peripheral arterial disease, so it's very common. And the morbidity and mortality is extremely high. About a quarter of patients will have a limb amputated at 1 year after being diagnosed with this. The primary revascularization strategy could include a surgical bypass or an endovascular therapy, but there's been really very few prospective randomized control trials to compare these strategies. And so we don't really know which one is better. Most people will point to the BASIL trial, which was an old trial published in 2005 that showed similar rates of amputation-free survival for both surgical and endovascular therapies. And so I'd say most people in clinical practice, it seems like, have transitioned more to an endovascular first approach. So the goal of BEST CLI was to determine whether endovascular revascularization was superior to surgical revascularization, and patients with chronic limb-threatening ischemia caused by infrainguinal peripheral arterial disease were judged to be suitable candidates for both approaches. This was an international prospective randomized open label multi-center superiority trial. They enrolled at 150 different trial sites in 5 different countries. The major inclusion criteria was that they had to have a diagnosis of chronic limb-threatening ischemia, which they defined as ischemic foot pain at rest, a non-healing ischemic ulcer, or gangrene. And the major exclusion criteria was patients who were not candidates for either surgery or endovascular therapy. They really wanted really wanted all patients involved to be considered to be good candidates for either approach. So an interesting part of this trial was that before they randomized patients, they actually all had a duplex ultrasound of the right and left great saphenous veins, and then they were separated into 2 different cohorts. Cohort 1 consisted of patients who had a single segment of saphenous vein that could be used for their bypass, whereas cohort 2 were patients who needed an alternative bypass conduit. Patients in each cohort were then randomly assigned to receive either surgical or endovascular treatment. And the primary outcome was a composite of major adverse limb events or all-cause death. Major adverse limb events was defined as an above the ankle amputation of the index limb or a major index limb reintervention. So looking at the results, 2,525 patients were screened, 1,434 were randomized to cohort 1, meaning they had an appropriate saphenous vein for harvesting, whereas 396 were randomized to cohort 2. I want to point out that a pretty large number did not complete the trial. So 29.1% of patients randomized to cohort 1 either withdrew consent or lost to follow-up, did not consent to follow-up, or had early site closure. And similarly, in cohort 2, 18.7% of patients did not complete the trial either. Looking at the baseline comorbidities, they were pretty well balanced overall with no major differences between groups. I will point out that GDMT was very low in both cohorts of this real-world population. So the use of statins was only 70 to 77% in all patients in this trial. The use of antiplatelet agents was less than 2/3, and the use of a DOAC was less than 5% overall. So there's a lot of room for improvement in guideline-directed medical therapy as well. So looking at the outcomes for patients in cohort 1, the patients who underwent the surgical approach had a lower risk of that primary outcome. Only 42.6% met the primary outcome over a median follow-up of 2.7 years versus 57.4% in the endovascular arm. And so that came out to a hazard ratio of 0.68 with a 95% confidence interval of 0.59 to 0.79 and a p-value of less than 0.001. When you look at what was driving this primary outcome, there was really no difference in death between groups. There was a slightly higher risk of above the ankle amputation in the endovascular group that was 14.9% versus 10.4%. But really the major thing that drove this difference was reinterventions on the index limb. You can see that in the endovascular group, 23.5% needed a major reintervention versus only 9.2% in the surgical group. And I think a lot of this comes down to technical success rates. For surgery, the success rate was 98.3%, but for the endovascular group, the success rate was only 84.7%. That's quite a bit lower than anyone would have expected. In most contemporary studies, the success rate of an endovascular approach should be about 95%. And so that difference of 13-14% could explain why this primary outcome, that could have driven the primary outcome alone, because you have to imagine that patients who did not have a successful endovascular therapy will ultimately need reintervention in the future. Looking at the safety outcomes, you would expect that patients undergoing the surgical approach would have a higher upfront risk, but there's actually no major difference in safety or serious adverse events, either in the short 30-day follow-up or longer-term follow-up of the study. So again, the only major difference here was that success of the index procedure, which was much higher in the surgical group. Looking at the Kaplan-Meier survival curves for the major outcomes, you can see in A, this was major adverse limb events or all-cause deaths. That's the primary outcome. And you can see that, again, these curves separate very early in favor of the surgical group. And again, that was primarily driven by major reintervention, which you can see in B, and those curves separate almost immediately in favor of the surgical group. Above the ankle amputation was also significantly different. You can see those curves start to separate a little bit after about half a year. And there was no difference in all-cause death. So I'm looking at cohort 2. These were patients who needed an alternative bypass conduit aside from the great saphenous vein. There's really no difference here in major adverse limb events or all-cause death. And looking at the secondary outcomes, there was no difference in death or above the ankle amputation. But again, there was a much higher rate of reintervention for those undergoing endovascular therapy. That was 25.6% versus only 14.4% in the surgical group. And again, I think that kind of comes down to the technical success rates being extremely low in the endovascular group, only 80.6% versus 100% in the surgical group. Looking at the safety events for cohort 2, there was again no difference in safety outcomes, either in short or long-term follow-up. So some of the key points about the BEST CLI trial does show that in patients with a good quality great saphenous vein for conduit, surgery was associated with about a third lower risk of a composite of major adverse limb events and death. That was, again, mostly driven by fewer major interventions as well as above the ankle amputations. Whereas patients who did not have a great saphenous vein for conduit, the overall efficacy and safety outcomes were similar between groups. Surgery doesn't seem to have any higher risk of severe adverse events, either early or in long-term follow-up. And then the final point here is that the optimal use of GDMT is obviously low in this real-world cohort and shows another area that could be improved upon. Major limitations in this study. So the planned number of enrolled patients was not met due to funding issues that they ran into towards the end of the trial. Because investigators used their preferred techniques, there was some procedural heterogeneity within each trial group. Again, there was a very high rate of technical failure in the endovascular groups, and there was no explanation for these technical failures. And similarly, there was no procedural details regarding endovascular complexity that might explain why there was a high rate of technical failure. There's also no standardized criteria to define successful revascularization. This was basically left up to the operators to define for themselves whether they thought it was successful or not. And then, as I mentioned earlier, there was a large number of data missing in that final analysis. So now I'm going to transition into the ischemia extend trial, which was published in Circulation earlier this month. And so I think we're all familiar with the ischemia trial that was published a few years ago and compared an initial invasive strategy of left heart cath and guideline-directed medical therapy versus an initial conservative strategy of guideline-directed medical therapy alone for patients who have chronic coronary disease and moderate or severe ischemia on stress testing. The major exclusion criteria here included left main disease of at least 50%, a low EF of less than 35%, ACS within 2 months, and angina that could not be managed with medical therapy alone. And the initial trial showed that after a median follow-up of 3.2 years, there was no net benefit for the initial invasive strategy on the primary or major secondary clinical outcomes. So these are the original curves, the original Kaplan-Meier curves for all-cause death, cardiovascular death, and non-cardiovascular death after the median follow-up of 3.2 years. On the left, you can see there was no difference in all-cause death. In the center, you can see that there was no difference in cardiovascular death either, although these curves did start to separate a little bit around 4 years in favor of the invasive arm. And then looking at the right, you can see in non-cardiovascular death, there was actually a higher risk of this in the invasive arm compared to the conservative arm, and that started around year 3. When they took a look to see why these patients, what they were dying from, they saw that it was mostly from excess malignancy for whatever reason. And again, that was starting around year 3. So the point of ischemia extend was to assess whether there were differences really in just the mortality outcomes, all-cause mortality, cardiovascular mortality, and non-cardiovascular mortality over longer term follow-up. So again, these patients were initially randomized in the ischemia trial in 2012. And then after that trial was published, they transitioned to the extend trial, which extends the follow-up to a median of 5.7 years. They're planning to continue this until 2026, until they have a median follow-up of about 10 years for the final analysis. So 5,179 patients were originally randomized in the ischemia trial. 2,588 were randomized to the invasive arm and 2,591 to the conservative arm. For the extended period, a total of 4,285 patients were eligible for additional follow-up for mortality. And to be eligible, you had to basically survive that initial trial phase, not withdraw your consent, and not decline long-term follow-up. So they had a pretty good amount of patients that were able to be followed in this longer-term data. So there were 289 deaths after the initial trial. During this extended follow-up, they added another 268 deaths. And so the total deaths at this 5.7 years median follow-up was 557 that could be included in the interim analysis. I think the most interesting thing here was it showed that when you extend this follow-up a little bit longer, as I mentioned, you started to see those curves separate for cardiovascular mortality in the initial trial, and those continued to separate over this longer-term follow-up. So the cumulative event rate of cardiovascular death was 8.6% in the conservative arm versus only 6.4% in the invasive arm. That comes out to an adjusted hazard ratio of 0.78 with a 95% confidence interval of 0.63 to 0.96 and a p-value of 0.008. So it does seem that patients undergoing the invasive strategy do have less cardiovascular death in the follow-up. But when you look at the non-cardiovascular mortality, those curves continue to separate as well in favor of the conservative strategy. So the long-term non-cardiovascular deaths was 5.6% in the invasive arm versus only 4.4% in the conservative arm. And again, that seems to be mostly driven by malignancy. So those differences in cardiovascular and non-cardiovascular mortality offset each other, and there was really no difference in all-cause death over this longer-term follow-up. They did do subgroup analyses to look at patients with multi-vessel disease, which they defined as at least 70% stenosis and at least 2 vessels on the coronary CT. And as you can see here, it seems that the patients who benefited the most from the invasive strategy were those who did have multi-vessel disease, whereas there was no difference for the patients who did not have multi-vessel disease. With regards to non-cardiovascular death, there was really no difference in either, depending on the presence or absence of multi-vessel disease, but you can see that those curves did start to separate as well in favor of the conservative strategy. And then again, for all-cause death, even in those who have multi-vessel disease, there was no significant difference for an invasive versus conservative approach. They did quite a bit of subgroup analyses to see if there was any particular groups of patients who would benefit the most from an invasive or conservative strategy. And really, as you can see, there was no major difference between any of the subgroups that they looked at. So key points of the ischemia extend trial, it shows that over a follow-up of a median of 5.7 years, an initial invasive strategy compared with the initial conservative strategy results in a lower risk of cardiovascular mortality, but a higher risk of non-cardiovascular mortality and no difference in all-cause mortality. That higher rate of non-cardiovascular mortality remains unexplained. Again, as I mentioned, there was more deaths from malignancy in that invasive group, but that doesn't really seem to be biologically plausible because the timing between radiation exposure, development of a new malignancy, and then death from that malignancy over just 3 years seems to be, doesn't seem to be biologically plausible. And so this study will continue into 2025 for a median of 10 years of follow-up. Some major limitations here, they really are only looking at mortalities. We're not getting any of the other quality of life surveys or anginal indexes at this point. And they did mention that the determination of the cause of death was often challenging due to the variable amount of information present in different systems. Okay, so now I'm going to hand this over to Dr. Melvin's daughter, who's going to present the second half of the presentation.
Thanks, Tom. That was an excellent first half. And now we have Dr. Melvin's daughter, who's a second-year cardiology fellow here who went to medical school at University of Iceland and residency in University of Wisconsin-Madison. Then she spent 2 years in a T32 program at Weidrich with Dr. Alcinousis, focusing specifically on multimodality imaging and understanding LV remodeling after MI using in a translational model. And then her career interests include advanced cardiac imaging, including structural echo. So Inga, please take it.
Thank you. So I want to start with the EMPA-KIDNEY trial. So this was presented by Dr. David Price at the late breaking sessions at Sunday, November 6th. So as you all know, large trials involving patients with diabetic kidney disease and a broad range etiology of heart failure have shown that SGLT2 inhibitors reduce the risk of progression of kidney disease and cardiovascular deaths and hospitalizations. We have limited data on eGFR of less than 30 and how these benefits might vary among the wider populations of patients with CKD. This trial aimed to include large number of patients without diabetes and with patients with eGFR less than 30 and patients with low levels of proteinuria. So this was an international randomized parallel group double-blind placebo-controlled clinical trial. It involved 241 centers in 8 countries. The inclusion criteria were race-adjusted eGFR of at least 20, but less than 45, and this was regardless of proteinuria. And then race-adjusted eGFR of at least 45, but less than 90, with urinary albumin to creatinine ratio of at least 200. And these patients were required to take dose-appropriate ACE inhibitors. So if for whatever reasons patients were not able to take ACE inhibitors, they were excluded from this trial. Other exclusion criteria included polycystic kidney disease and patients that received kidney transplants. So all eligible patients, they entered this pre-randomization run-in phase and then were provided with a 15-week supply of this once daily placebo tablets. And then after the completion of these run-in phase, these patients were then randomized to 1-to-1 empagliflozin or placebo. So the authors determined that a first occurrence of a primary outcome event among the first 1,070 patients would provide the trial with 90% power to detect a risk of primary outcome event that was less than 18% lower in the empagliflozin group rather than the placebo group. So the primary outcomes were twofold or composite of two things: deaths from cardiovascular causes, and then first occurrence of progression of kidney disease. And the authors defined this as the initiation of maintenance dialysis or receipt of a kidney transplant, a sustained decrease in eGFR less than 10, or a sustained decrease from a baseline in the eGFR of at least 40%, or a death from a renal cause. And then all analyses were performed according to the intention to treat principle. So these are some of the secondary outcomes: composite of hospitalization for heart failure or death from cardiovascular cause, death from any cause, and then progression of kidney disease, death from cardiovascular causes, and then a composite of end-stage kidney disease or death from a cardiovascular cause. So the study was done in February 2019 through April 2021, so right in the middle of the COVID pandemic. On March 7, 2022, the Independent Data and Safety Monitoring Committee reported that on the basis of 624 first primary outcome events, both conditions for stopping early for efficacy were met, and at the time of the formal interim analysis. So follow-up was completed on July 5th, 2022, at which time the median follow-up was about 2 years. So a total of 8,544 potential participants attended a screening visit. About 96% of those patients, or 8,184 patients, entered this pre-randomization run-in phase with the placebo tablets to ensure adherence. And then finally, 6,609 patients, or about 77% of the initial population, underwent the actual randomization. There was completed follow-up in about 99% of the patients in both groups, and a median follow-up was 2 years, like I mentioned before, with adherence at the midpoint at the midpoint of the study of about 90%. And about less than 1% of the participants started open-label SGLT2 inhibitors by the final follow-up time. So here are some of the basic characteristics of the patient population. Just wanted to point out a few to you. The mean age of these individuals were 64 years in both groups. About 33% were women. Only 4% of the patient population were of a Black race, and 54% had no history of diabetes, and 73% of the individuals in both groups had no history of cardiovascular disease. And the mean eGFR of the patient population was 37. So here are the results of the primary composite outcome of progression of kidney disease or death from a cardiovascular cause. So again, over a median of 2-year follow-up, progression of kidney disease or death from a cardiovascular cause occurred in 432 patients, or 13% in the empagliflozin group, and in 558 patients, or almost 17% in the placebo group. And this represents about 42 fewer primary outcome events per 1,000 patients in the empagliflozin group compared to the placebo group over 2 years. And here are some of the components of the primary outcomes. The hazard ratio for the comparison of empagliflozin with placebo with respect to progression of kidney disease was 0.71. It was statistically significant, again, favoring empagliflozin. The hazard ratio for a composite of end-stage kidney disease and cardiovascular death was 0.73, again favoring the empagliflozin group compared to the placebo. However, looking at the cardiovascular death alone, there was not statistically significant with a 1.8% occurrence in the empagliflozin group and 2% in the placebo group. So the effects of the empagliflozin treatment with respect to the primary outcome was generally consistent across the pre-specified subgroups. In particular, the benefits of empagliflozin treatment were consistent among the patients with and without diabetes, and regardless of the eGFR at randomization. And there was some evidence also that the proportional risk reduction may have been a little bit larger within the patients that had higher urinary albumin to creatinine ratios. So there was also an initial overall decrease in the eGFR in both groups. However, in the empagliflozin, there was an acute decrease in the eGFR when the trial regimen was started. However, then the annual decline of the eGFR slowed. However, this decline seemed to be steady in the placebo group here. So overall, looking at the whole time period, the between group difference in the eGFR slope from randomization to the final follow-up visit was 0.75, favoring, again, empagliflozin. However, these values are labeled as long-term. They represent the mean changes from the first 2 months after starting the dose of empagliflozin or placebo to the final follow-up visit. So this would be equivalent about halving the rate of the decline in the eGFR slope within the empagliflozin group compared to the placebo. So these are some of the other secondary and safety outcomes. I just wanted to point out that there seems to be a significant difference in decrease in hospitalization for any cause. However, looking at death from any cause, there seemed to not to be any statistical significance. And there appeared to be no increase in the serious adverse events with the empagliflozin group. So some of the limitations and strengths of this study. So the limitations are that there were lower than expected number of cardiovascular events, and this may have reduced the statistical power of the secondary outcomes. The main strength of this trial, this is a large trial, they had pretty broad eligibility criteria and had a pretty impressive high level of adherence and almost complete follow-up of patients. So some of the conclusions that we can draw from the EMPA-KIDNEY trial. So they randomized about 6,600 patients with chronic kidney disease with a broad range of causes and a large number of patients with low levels of kidney function and albuminuria. So empagliflozin safely reduced the composite primary outcomes of kidney disease progression or cardiovascular death by about 28%. And relative benefits were consistent in patients with and without diabetes across the range of eGFR studied. And then finally, the slope analysis showed that the empagliflozin seemed to slow the chronic eGFR decline in all albuminuria subgroups. So now I'm going to switch gears a little bit and talk about the DCP trial, or the diuretic comparison project. The title is chlorthalidone compared to hydrochlorothiazide for prevention of cardiovascular events in patients with hypertension. So this was presented by Dr. Ravi Fishani at the late-breaking sessions, November 5th, 2022. So the major question that the authors wanted to answer from this trial was if the treatment with chlorthalidone would reduce the risk of major adverse cardiovascular events compared with hydrochlorothiazide in older veterans with hypertension. So studies from the 90s and early 2000s showed evidence that patients treated with chlorthalidone had better cardiovascular outcomes compared to other treatments and overall better hypertension control. However, chlorthalidone carries the increased risk of adverse events such as electrolyte abnormalities and acute kidney injury. So far, we have not had a head-to-head studies that compare hydrochlorothiazide and chlorthalidone for better cardiovascular outcomes. So this is a slide provided by Dr. Ishani. Again, the goal was to evaluate the safety and efficacy of the hydrochlorothiazide and then comparing it to chlorthalidone and improving cardiovascular outcomes among the elderly patients with hypertension. So they took patients who were already taking hydrochlorothiazides and randomized them either to continue the hydrochlorothiazide or switching them to chlorthalidone. So it was a one-to-one randomization. It was an open label, pragmatic trial design. And again, patients that were taking hydrochlorothiazide 25 milligrams, they were converted to 12.5 of chlorthalidone, and individuals taking 50 milligrams of hydrochlorothiazide to 25 of chlorthalidone. Other inclusion criteria, again, individuals over 65 years of age, and they had to have a mean systolic blood pressure above 120 millimeter mercury. So here are some of the primary secondary outcomes. The primary outcomes was the time to first occurrence of either myocardial infarction, stroke, hospitalization for acute heart failure, unstable angina with urgent coronary revascularization, or non-cancer death. And I mentioned here some of the secondary outcomes and some expected adverse events that they were monitoring for as well. So this is the diagram for the study participant. Roughly 80% of the pre-screened patients underwent one-to-one randomization, and analysis was then done with the intention to treat principle. But I want you to note that about 94% of the patients that were allocated to the chlorthalidone group were prescribed 12.5 milligrams of chlorthalidone. So only about 6% of the patient population under the chlorthalidone group received 25 milligrams of chlorthalidone. The median follow-up was about 2.4 years in both groups, and completed follow-up was performed in about 93% of the patient population in both groups. So this is a tablet, again, provided by Dr. Ishani. I just wanted to point out a few baseline characteristics for you. So the mean patient age was about 72 years in both groups. Percentage of female is 3%, which is not surprising that this is coming from a VA population. African-American individuals were 15%, mean BMI of 32, and about 44% of the individuals had diabetes, prior history of diabetes. And I want to specifically mention the individuals that had a prior history of myocardial infarction or stroke, which is about 11% in both groups. And also, there were only 13% of patients that were on hydrochlorothiazide monotherapy for hypertension at baseline. So again, this is a figure provided by Dr. Ishani. There was no significant difference in the blood pressure numbers or control over time between the both groups. And there seemed to be an increased risk of hypokalemia in the chlorthalidone group as well. So the principal finding, the primary outcome, again, the composite of major adverse cardiovascular events, or MACE, for chlorthalidone versus hydrochlorothiazide was non-significant, with a hazard ratio of 1.04, with a 90% confidence interval of 0.94 to 1.16. So none of the other secondary outcomes were significantly different either between the groups. However, I want to point out to you that the hypokalemia appeared to be more common in the chlorthalidone group, about 6% compared to the hydrochlorothiazide group, 4.4%, which was statistically significant. So remember, I mentioned the individuals with a history of MI or stroke. Again, these were about 11% of the patient population in both groups. And patients with a history of MI or stroke who were receiving chlorthalidone had a significant 27% reduction in the primary endpoint, with a hazard ratio of 0.73, and was considered to be statistically significant. However, looking at the patient population that were had no history of MI or stroke appeared to have worse or do worse compared to the the hydrochlorothiazide group compared to the chlorthalidone group. So some of the limitation and strengths of this study, the primary limitations of this study is that the majority of the patient population was on the lower doses of chlorthalidone compared to prior studies for chlorthalidone. It seemed that the literature prior is more involves individuals taking 25 of chlorthalidone compared to the 12.5 in this study. This was an open label design and a pragmatic trial, which always carries some limitations. And outcome determination based on the VA records and Medicare claims data as well. And we don't have any data about compliance, and these results also could be affected by concomitant medications or doses. Again, remember, there are very few patients that were on chlorthalidone monotherapy or hydrochlorothiazide monotherapy upon randomization. Also, just the fact that this is a VA population carries some limited generability of the results at as these patients were primarily white males. Some primary strengths of this study, the study recruited a large population of patients living in rural areas, a patient population that is often missed in a large academic studies. And this was a non-intrusive, cost-effective, and inexpensive trial design. The patients can continue with the normal care with their usual primary care team. And also the fact that the patients were followed through the electronic medical records, the CPRS, I presume, as well as the Medicare claims data makes this very inexpensive trial design. So the conclusions that we can draw here, the primary conclusions from the DCP study, which was conducted in more than 13,500 US veterans aged 65 years or older, are that there are no difference in blood pressure control, and it showed almost identical rates of the primary composite endpoints, including myocardial infarction, stroke, non-cancer death, hospitalization for acute heart failure, or urgent revascularization after a median of 2.4 years of follow-up. Hypokalemia was more common in the chlorthalidone group, which has been previously shown. However, again, I want to mention in the subgroup of patients who had the history of MI or stroke, who again were about 11% of the patient population, had a significant reduction in the primary endpoint with chlorthalidone, whereas those without a history of MI or stroke appear to have increased risk for primary outcome events while receiving chlorthalidone compared to those receiving hydrochlorothiazide. So then I finally just want to do a brief review of the CRISPR-Cas9 in vivo gene editing trial for transthyretin amyloidosis. And this was presented by Dr. Julian Gilmore Saturday, November 5th, 2022 at the late-breaking sessions. So as you're all familiar, transthyretin amyloidosis is a progressive, debilitating, and ultimately fatal disease caused by accumulation of amyloid, mainly in the heart and in the nerves. This NTLA-2001 is a CRISPR-based gene editing therapy, which is given by intravenous infusion and then is transported directly to the liver and inactivates the transthyretin or TTR gene and reduces the production of the transthyretin protein. In August 2021, the New England Journal of Medicine published interim data from an ongoing clinical study evaluating a single ascending doses of this NTLA-2001 for TTR gene editing and knockout in treatment of 6 patients with hereditary TTR amyloidosis with polyneuropathy. So this drug was considered to be associated only with mild adverse events and led to significant decrease in serum TTR protein concentration through targeted knockdown of the TTR gene. So this trial, CRISPR-Cas9, is a first-in-human study. It's a 2-part study comprising of a dose escalation phase and a dose expansion phase. So this is an open-label, multi-center study in adults with hereditary ATTR amyloidosis and dominant polyneuropathy, or alternatively, patients with ATT amyloid cardiomyopathy. So this data that I'm going to talk about today is from the dose escalation phase in patients with cardiomyopathy. So they had a total of 12 patients, 6 patients with New York Heart Association class 1 or 2 heart failure, and they had administered 2 doses, 1 milligram per kilogram and 0.7 milligram per kilogram. And then the other 6 patients had New York Heart Association class 3 heart failure symptoms, and they were only administered the 0.7 milligram per kilo dose. The outcome measures obviously were safety in this phase 1 first-in-human study, and then the measurements of pharmacokinetics and pharmacodynamics, and they measured the pharmacodynamics by serial measurements of the transthyretin levels as a surrogate marker of efficacy. So here are some of the patient demographics. All of the patients were male with the mean age of 75 years of age, and 50%, as I mentioned before, had New York Heart Association class 3 symptoms. So the authors showed that the NTLA-2001 treatment was well tolerated in the acute phase. Most adverse events were mild and were not attributable to the NTLA-2001 infusion. There was a single grade 3 infusion-related reaction, which resolved without any clinical sequelae. And no clinical laboratory findings were found. There was one transient grade 1 liver enzyme elevation noted. So all dose and New York Heart Association cohort achieved greater than 90% reduction in circulating TTR protein concentration by day 28. And that was sustained through the latest follow-up. The authors believe that the greater the TTR knockdown, the better the likely outcomes in terms of effect on the patient's disease. And this is based on the previous literature. So some of the future directions are using this method. So the main challenge with this particular treatment is delivery to the target cells. But the authors seem to have developed a pretty elegant method of using this CRISPR-Cas9 based in vivo gene editing that can be used to target cells that are predominantly expressed in the liver. So Dr. Gilmore mentioned hemophilia A, hemophilia B, alpha-1 antitrypsin deficiency, and others. Also in the far future, this might also give us a potential to edit multiple genes, and this might benefit patients who have certain forms of cancer. But again, this is a little bit further down the road. The authors are planning to continue to follow these patients for long-term safety outcomes and effects, and we await the publications eagerly. By that, I'm going to say thank you so much, and hope for any questions that the audience have for us.
So that was an excellent overview. Thank you both. It covered everything perfectly. I think we have a little time for questions, and I'm not going to put you guys on the spot for answering for the other investigators who led the study. But if there are discussion points here, Eric and Ed are here. Maybe I'll just pose a quick question. So with the idea of ATTR therapy and gene, is this technology, are we looking to participate in future trials? What is the pulse on gene editing technology at Yale with respect to other institutions? I know it's only 12 individuals and so forth, but it will have implications in the near future.
Yeah, thanks, Ingo. That's a great presentation on a really important study, and it's really interesting to see that there are very few adverse events in that study. As you mentioned, the most important thing is because TTR is a liver-produced protein, is a perfect target for this particular technology. The range of TTR reduction is similar to what's being seen with the siRNA agents, so the efficacy will probably be similar. But obviously, this has some benefits, I think, in terms of potentially. In terms of our involvement, we've been approached to be participants in upcoming phase 3 study. I think the planning for that is ongoing, and hopefully will be a site.
Awesome. Yeah, Eric.
Matt, I want to ask a question, not about particularly that you guys have great work. Thank you for teaching us about these studies. Maybe to ask each of you, in the process of preparing for this review for the faculty and fellows and staff, what did you learn about in regards to what is a kind of a take-home message for the perspective of reviewing studies? Sometimes it takes nearly a decade to complete, and presenting it in a short format like this. What are some of the take-homes that you have in this process?
I think it was challenging to take, each one of these studies could have been a full grand rounds by itself. So I think it was challenging to try to come up with the most important pieces of the study to kind of lay out and still give a good overview of some of the strengths and limitations of it.
particularly because some of the studies haven't been published in full, so we only really have, limited, and kind of depending on on what the author sent to us, and they were kind to do so at the end. Also, I would want to say that I feel like there was such a broad range of discussion topics and studies that were presented on AHA. So you maybe were a little bit overwhelmed at first, but I felt like some of these studies, at least what I chose, were interesting and like new and something that has been on my mind for a very long time. So for example, that DCP trial, that chlorthalidone and hydrochlorothiazide, that was something that had been in my mind for a very long time. So I was very thankful for that study. But yeah.
Yeah, I mean, I would just comment that I think that this is the process of we all are going through, and that no matter where you are in what stage of your career, I think is trying to prune information down. And when you go to the American Heart Association, you have to choose which sessions to go to as a starting point, and then you can only see so much. So I think it's a really great exercise to kind of bring it, kind of bring it to its kind of elements, main elements. And I think you guys did a great job. Thank you. I was just going to comment on just the best CLI trial, and be curious. We have Jeff here, who might certainly give us a perspective as well as an interventionalist. But I think one of the challenges of a study like that is that everyone feels they have the answer, and so there is true equipoise, but the equipoise exists differently in different groups of individuals. And if you try to, one of the opportunities that clinical trials provide is by expanding the entry point across multiple sites in some countries, you actually create some generalizability in that process. Generalizability of different sites having different levels of equipoise that's smoothed over 150 sites. And that's an advantage. I do think the having such a large percent of patients not losing information at the point of randomization, I think is a challenge. And one of the ways that you can address that challenge is by trying to build clinical trials within registries. And so we have one of the world's experts in registries here behind you. And I'm curious about your sense about what the ACC or the NIH or other Sweetheart or other groups are doing with regards to trial embedded, registry embedded trials.
Great question. Yeah, no, I think it's the latter part's the easier one to answer, which is that there's still enormous interest in getting the infrastructure together to do randomized trials within registry frameworks. And Sweetheart, we've been talking about for 15 years, and we still haven't been able to replicate it here in a reliable and sustainable fashion. So, currently at the NCDR, we're working with investigators from CRF on a pragmatic study within TVT registry, and hopefully that's the start of many. The funding for this and industry, particularly device industry, is a little apprehensive about investing in this. And so I think it's a matter of getting enough small wins that we can prove that this is a valid way to do science, which I think it is. Regarding best CLI, I mean, it's interesting, because I think maybe your own biases were leaking through.
I noticed that.
And I had a different, set of biases on it. But I think this is probably as close to an answer as we will ever get with this very challenging population. And I do think that it's worth reflecting on our own practice here. And actually had talked to Raul in the hallway last week about what are the implications for that here, and it actually suggested that we put that into our safety quality grand rounds as sort of a reevaluation of what we're doing, or an ongoing discussion of how we're going to deliver the best care for our patients. I do think that my take home is that if you can get a saphenous vein graft, if I had critical limb ischemia, I probably would take the saphenous vein graft for both the longevity as well as the reduced likelihood of reduced risk of amputation. I think it's not 100%, but it's close enough that you know, it would impact what I would do. And on the other hand, there's differences. I don't think he got into the quality of life differences which favor endovascular work. So there's kind of an interesting duality to that we'll have to sort through. And then just to acknowledge that, you know, Carlos Mena was a co-author on that, which is a testament to his commitment to that trial. And I think we were one of the top enrollers on the basis of him and his team's work.
Thanks again, and we'll see you next week. Thanks again, Tom.
Great job.